Welcome everyone. I'm going to invite Henry to my co-chair to join us with her webcam.
Morning everyone, or I guess it's afternoon now.
That's right, it's afternoon, thank you. Well, good afternoon everyone. I'm Catherine Brookman from CRE-MSD, and I'd like to welcome you to this webinar on behalf of CRE-MSD and Public Services Health and Safety Association. I'm joined by my co-chair Henrietta Van Hoo from PSHSA, and I'd like to acknowledge the support of our technology team here, Bettina Butler and Trevor Baines from the University of Waterloo. The process for today's webinar will involve a brief introduction of our speaker. We will have a presentation and an opportunity for some questions and answers. After the questions and answers, we will certainly have an evaluation sent out to you, and you will be able to access the webinar through an audio feed, and also the PowerPoint presentation will be available to you. Should you have any technology glitches during the webinar, if you type them into the chat box, we will attend to those as we see them. Also, to maximize your time, we ask that unless you have a very pressing question, we will address any of your questions at the end of the webinar, but we will monitor what you type into the chat box just in case there is a pressing question. So Henry, did I miss anything?
No, I think we're good to go.
All right. Well, I'm going to turn this over to Henry and ask her to make the introduction to our speaker.
So welcome everyone. It's great to see we have 40 participants now on the webinar, and thank you Catherine and CRE-MSD for co-hosting this with us. I'm going to introduce our speaker for today's webinar. It's Claudette Walsh, and she has been with CBI Health for 20 years. This last 17 of those, she's been working in CBI's Workplace Solutions division. She's a graduate of the University of Waterloo Honors Kinesiology program, and for the last 19 years, she's been working in the area of injury management and prevention in the workplace. She's been delivering education sessions and programs to managers, supervisors, and frontline workers for a number of years. She's been done a number of ergonomic assessments across a vast span of industries. She does physical demands, profiles, and analysis, offers post-offer employment testing, and functional abilities evaluations and assessments. She has been a speaker in many industries at several conferences and workshops, particularly around injury prevention and injury management. For the past 7 years, Claudette has been involved in facilitating PSHSA's Handle with Care client education program. And this is the hands-on education program that was developed by our former iteration of PSHSA, which was Healthcare Health and Safety Association, and then OSACH. And CBI Health and CBI Workplace Solutions have been delivering the hands-on and train-the-trainer component of our Handle with Care program for about 20 years. And Claudette herself has probably delivered over 300 Handle with Care sessions in the long-term care and community sectors. So through those 300 sessions, she's learned a lot from participants. She's heard a lot about barriers and been able to provide a lot of workable solutions in both of those settings. So I'm going to turn it over to Claudette so she can share everything she's learned in those 300 sessions with us in the span of about 50 minutes.
Thank you, Henry. That was great. So I am going to try to share as much as I can with regards to some of the barriers that people have expressed to us, mainly from the frontline workers. We'll go over some of those things, as well as some of the solutions that we've seen that have been quite effective across the province.
Sorry,
So
Claudette.
hopefully we can get in.
Claudette,
Yeah?
could you start your webcam?
Oh, sorry, thought it was. There it is. Okay, sorry, my apologies. Okay, thank you. So I'm hoping that we can share as much information as possible over the next, sort of 50 minutes, and any feedback you have would be fantastic. So what we want to cover off today is we'll talk about some of the general principles of Handle with Care and sort of why I think the philosophy does work. And then we'll get into some of the common misconceptions and the possible solutions. And a lot of these solutions are things that we've actually seen in place. So these are not just something that that we're suggesting or offering. It's just through the past 17 years that I've been involved in this program and been in a different number of environments. We have seen, community organizations, long-term care, even hospitals making these things work. And I know that, oftentimes in healthcare, people are short-staffed and there isn't a lot of resources. But as I said, it has worked. And so I think if people can sort of share ideas, then people can, sort of come up with better solutions and help to decrease the injury risks. So I'm not going to spend too much time on the slide because Henry did a great job talking a little bit about the history. So we have been providing this program for nearly 20 years. And as I said, I've been involved with it probably for about 17 years now. So people often wonder whether or not education is really effective when it comes to reducing the risk of injury within healthcare. And the Institute for Work and Health has done some research in the area. And one of the things that they have found is that there is support, there is evidence when they look at their systematic reviews. They're pulling together a bunch of studies that does show that 2 interventions have had a positive effect when it comes to reducing the injury risk within healthcare. And one of those things is having, patient handling, having sort of 3 components to it. So I think one of the most important things is making sure that there are solid policies in place which help to support the program. So things such as, the zero lift policy was one of the things that it was popularly called, or minimal lift policies. The other thing is making sure that there is equipment available to staff. And many of you may remember that there was a very big initiative back in around 2005 where there was a huge amount of funding dollars that were given to organizations in order to implement equipment. And with that came along some funding dollars for education. And one of the reasons why that education funding was there is because of the fact that there has been evidence to demonstrate that, having the equipment is great, but we also need to have training programs for the frontline workers to be able to understand how to use that equipment safely. And then not to forget all those, important principles regarding, proper body mechanics. So the second thing that their studies looked at is the fact that exercise training programs are also effective when it comes to looking at the reduction of musculoskeletal injuries within the workplace. So there's 2 important components to the Handle with Care program, and one of them is the comprehensive client handling, having a comprehensive client handling program in place, and the other one is the training. And I think, the real sort of backbone to the program is making sure that the policies and procedures are solid. And I know that Francis Zeisman from the organization did give a presentation, I think, a while back, and the slides are actually available on the website if you'd like to go back and take a look at that. But she actually went through a little bit more about the client handling program with regards to the policies and procedures and making sure that you have a good comprehensive program in place. And CBI is more responsible for providing the hands-on training with regards to lifts, transfers, repositioning, and the client mobility assessments. So having those policies and procedures in place do create the foundation to any program. I think it's important that you have the commitment from the top down. And one of the things that we've heard time and again from the frontline workers is that they feel that there is a lack of support and commitment from the top down. They sometimes express frustration with the fact that these policies and procedures are in place and they're written on paper, but there doesn't seem to be any visible support and commitment from the organization to see those policies through. And I think that's really, really important, because if you don't have that visible support, then they feel as though it's just being put in place for good measure, rather than because the employer actually cares about their well-being. So I think that's one of the, if that's one of the first things to look at, is making sure you have those policies and procedures, but are you really standing behind them and showing that support? Anytime you have a program in place, it's always important to make sure that you continually evaluate that program, update it as it's needed. Is new equipment in place? Is there new sort of environmental design considerations that you need to take into consideration? Update those policies and make sure you provide training on those things. The other thing is making sure that all staff have been trained. So again, we've seen time and again where we're asked to go in and do training, and we are training the frontline workers, but supervisors and managers are not present. And again, this can lead to some frustration for some of the frontline workers, because they feel as though they're being told to do things differently, and yet they're not getting that support from upper management. So I think it is important to make sure that whether it is a separate session that supervisors and managers are attending, so we can say, yes, they have been trained and they're hearing the same information that you are, because I know that we've had some concerns from supervisors and managers saying, well, we're worried that if we're attending, they may not behave in the same way, that it might create a bit of tension in the room. So if that's the case, separate training can be done, but I think it's important that everybody hear the same message. And that's, going to help with, creating change. The other thing is making sure that the training is ongoing. There are some places we go into on an annual basis, and there are some places that we seem to go into once every 5 years. And it's not as though the training has to be the exact same every single year. Some of the core components need to be the same, to remind everybody about the policies and procedures, to remind people about, the use of proper body mechanics. But there's nothing wrong with tweaking that training each year depending upon what the needs are. So whether you do a survey, find out what people sort of want to learn a little bit more about. It's amazing how many people don't feel comfortable using the equipment that is in place because the training may only be done, once a year or once every 2 years. And so you find that people are reluctant to use the equipment just because they don't feel comfortable with it. So I would certainly recommend putting out sort of anonymous surveys where people can provide suggestions with regards to what do they want to see in their upcoming annual training. And the other thing is to make sure that you evaluate the training effectiveness. Looking for feedback forms. Are you doing small surveys after the training? There have been some organizations we've gone into sort of 3 months down the road and sort of done mini audits, and to see whether or not things are being carried through. So are client assessments being done? Are the results of those client assessments sort of being clearly identified, communicated to the staff? Are they then following through on those things? So there's different things you can do in order to evaluate the training effectiveness and see whether or not you maybe need to do things differently, or if things are going great, then fantastic, continue on as is. So with the client handling program that CBI presents, I'm only going to spend a little bit on this, but there's essentially 5 modules that we go through. And the introduction is basically to review the objectives and goals, as well as to look at some of the current rates in terms of injuries, where we're seeing the injuries happen, whether it be the client handling piece, whether it be trips and falls. But it just kind of gives some people a little bit of information with regards to where injuries are happening. The next important piece is the client mobility assessment. Now, when we do full day training sessions, then there is a fair bit of time spent on the client mobility assessment, because the goal is to actually train identified individuals to complete those client mobility assessments. When we only do half-day training, we focus more on something called the mini assessment, which I'll talk a little bit about later on. So then we go through the client repositioning and transfers, as well as the mechanical lifts and lateral sliding, and then we talk a little bit about the equipment and the environment. The program objectives, and I think this first one is really, really important, is trying to make sure that we're promoting the maximum participation and independence of the client handling procedures, whether it be lifts, transfers, and repositioning. And I think that sometimes frontline workers or people even doing the assessments, we are worried about trying to do things quickly, and we often forget about trying to make sure that we maximize their participation. But they are key, sort of individual, and we need to make sure that we are enabling them as best as possible. And one of the things we need to remember is when we do that, we also reduce the risk of injury to the caregiver, because if we are enabling that person to stand as best they can, then that means less strain on the caregiver. And so it's important that we slow down, that we actually take the time to communicate, to make sure that they understand what we're asking them to do, to provide that assistance and to then carry out that procedure. But I think that often gets forgotten about, and I think we need to keep going back to that key point. So the other thing we want to do is make sure we're enabling caregivers to assess all the risk factors to help select the appropriate techniques. So part of that is enabling caregivers to help problem solve, so that they can look for those risk factors. When has the individual's abilities changed? And when they have changed, if we don't have time to get an assessment done, what can they do to problem solve so that they can safely enable that person to move from point A to point B? The other thing is making sure that we have consistency. And oftentimes I find that we are lacking a lot of consistency. Different techniques are being used. And I'm okay with different techniques being used for client A versus client B. But the problem is that we have the same client being moved in different ways by different individuals. It creates a lot of confusion, for the client. And so what can end up happening, especially if you have somebody who has any kind of resistive behaviors, it can actually increase that, because what we're doing is not predictable, and they often rely on having things that are predictable and routine. And so it's important to make sure we have that consistency. We want to make sure that caregivers are really good at communicating, not only with the clients, but with other caregivers. And I find that this is probably one of the more frustrating things that I've seen over the years, is the number of times that I have observed caregivers going into, let's say move somebody in a mechanical lift, and not only do they not speak to each other because they feel as though they've done this so many times, but the other thing is they're not actually communicating with one of the most important individuals, which is the client. And I feel strongly about the fact that we need to communicate with all clients, regardless of whether or not we feel that they understand. So whether there be language barriers, whether there be any concerns with regards to dementia, but it's really, really important that we communicate. I had a lot of firsthand experience with my father, who was in long-term care for a number of years. He had Alzheimer's. He was one of those very aggressive, resistive, one of those, sort of poster people when it comes to resistive behavior. And when I would sit back and watch the caregivers, the people that had the greatest success, I would say, in terms of sort of getting him into that mechanical lift, would be the people that were, the caregivers that were talking to each other, because it sort of created a calmness. In a very calm voice, they were talking to each other. But the other thing is they were actually talking to him, even though at that point he really, it would appear he wasn't aware of what was going on. But he was certainly less combative when there was greater communication. So that was a very interesting firsthand experience for me. The other thing is to make sure that we are teaching caregivers proper body mechanics. And I know a lot of times we've got posters everywhere. We've got a lot of information out there, but I think it's important to give the caregivers the opportunity to actually practice these things in sort of a safe environment, because the more you practice in that sort of quiet environment to use good techniques, it's easier to then transfer that onto the floor. The other thing is making sure that there's consistency in terms of the documentation of any techniques that are supposed to be used with the client. So one of the things that was developed many, many years ago was the logo system, and I really like the logo system. I know there has been some sort of talks through the years whether or not organizations were comfortable using the logo system, and in speaking to a number of different people, it was felt that the logo system, it doesn't interfere with privacy, because of the fact that it is sort of a stick figure. It is only sort of indicating the type of technique that is supposed to be used with that individual. So it might be a one-person minimal assist, a two-person transfer, it could be a mechanical lift. And with some of the mechanical lift ones, I know they were using, excuse me, sorry, the sling size, they would just write that on there, or the type of sling that was going to be used just in the corner. But it's a very easy and consistent way to communicate to the frontline workers, how that person is supposed to be sort of assisted or moved. And, some organizations have whiteboards, whatever works for you. But I think there needs to be something easy rather than something documented and put into a file that people can't easily access. So again, some of the key components with the training programs is that whole musculoskeletal disorder awareness, reviewing those important biomechanical principles. And I think it's really, really important to make sure that those are reviewed because of the fact that it enables those caregivers to problem solve. If they know that they need to keep the weight as close to their body as possible, maintain those neutral curves, don't twist, then, in addition to some other ones, but if you can remember those key principles, it really does, sort of empower them to sometimes problem solve when they need to. If they can keep those principles in mind, they can certainly reduce that risk of injury. And the other thing is that there really needs to be some hands-on practice. So it's one thing to, sit around a table and talk about good body mechanics and to talk about, assessments and client mobility assessments. And it's another thing to actually do it. And so we try to make sure that, when it's the half-day program, that half the time is actually spent practicing, transfers, practicing using mechanical lifts. And with the full-day program as well, there's, usually at least, 2 to 3 hours that is spent on hands-on demonstrations. So making sure that we have beds available, equipment available to do the training properly. So some of the challenges and the misconceptions that we've seen, and this has been fairly consistent through the years. I think some of the things that the frontline workers have expressed is the fact that those assessments are not always accurate. And so there's frustration there because they feel as though they cannot rely on that information. The other thing we hear is that, well, if I use the proper techniques, it's going to take more time. We don't have enough staff. And then the other big one is they often feel that there's not enough equipment in place. So I think that, a lot of times, the solutions do tend to be common sense, but the thing is we've only seen them work when it's applied consistently. So not just consistently within, sort of one unit. It has to be across the whole organization that you have that consistency. And it's a lot of work. There's no doubt about it. It takes a lot of work to put a good client handling program in place, but it takes even more work to maintain a good client handling program, to continue to evaluate it, to get feedback from the staff. And that's really, really important because then you can hear their concerns and you can try to problem solve together as a team. So probably one of the biggest things we hear from the frontline workers in terms of those client assessments is they say they're not really accurate. They're not really indicating the person's abilities at this time. And then the other thing we hear is that there's not enough resources in order to assess mobility. So what ends up happening is we have the frontline workers saying, well, it's not accurate, and then we have supervisors and managers saying, well, we don't have enough staff to continually update these assessments, and any time that even doing it on a quarterly basis, but when their status actually changes. And as we know, sometimes their status can change rapidly, and it can go sort of from one extreme to the next. If there has been an injury or anything like that, then things can actually change. And so it's important that we have that information up to date. So one of the things that I find is interesting is that there's nothing that actually stipulates that client mobility assessments has to be completed by a registered staff. And this is something we've looked into time and again. And there's nothing out there that is actually legislated that says that it has to be registered, which means that it doesn't necessarily have to be an OT or PT doing those assessments. It could be somebody who is trained and competent in doing those assessments. So it could be the PSW, a sort of a lead PSW. It could be somebody who is part of the recreation staff. It can be anybody in the organization who is trained and competent in completing those assessments. It's really up to the organization to decide who is going to be responsible for those assessments and making sure that that person is actually trained or those individuals are actually trained. Now, there's nothing wrong with having the OTs and PTs doing it, but in most organizations in long-term care, hospitals, out in the community, the access to having a PT and an OT is sometimes quite limited, and they're not going to be available to do these assessments regularly or whenever the person's status has actually changed, and then they don't get done. And the problem is that those mobility assessments are not accurate, not reliable, then the staff just start doing their own thing. And then you have one shift doing one thing, another shift doing another, and it can create, again, a lot of confusion for the client. So it's important that we have appropriate and timely mobility assessments that are completed. So in the training, I think that the PSHSA has done a fantastic job with providing a really good algorithm to walk people through how to determine how that person is going to be moved. So are they going to be a one-person transfer, a two-person transfer? Is it going to be sort of the side-by-side transfer, front and back transfer? Will the person, be suitable for a mechanical lift or even for the sit-to-stand devices, the transfer devices? And the algorithm is great. It has, I know Francis worked really hard on getting that done. And the nice thing to me is that there's consistency, because if you do a basic mobility assessment and then you walk through that algorithm, if you have 3 or 4 people doing that assessment, you should all come to the same conclusion when you have an algorithm in place. Audrey Nelson is also a great resource in terms of having some good resources for those algorithms. So the other thing with regards to client assessments, we hear the frontline workers saying that the technique is not really effective on a day-to-day basis. So they get frustrated, they feel like they're not misunderstood. And so I think that one of the things that can happen is that if you do have only one individual providing those mobility assessments, it only may be done, let's say, in the morning or just in the afternoon. The OT or the PT will come in, or whoever has been designated, the RN, to do that mobility assessment. And they forget about the fact that there are many individuals whose abilities change based on the time of day. So in the morning time, some people, depending upon any kind of medical condition or anything that they have, they may actually be more stiff and not as mobile in the morning, so they require greater amount of assistance, to the point that some people are mechanical lift in the morning, and yet by the afternoon they are a transfer. Some organizations have taken the position that anybody who is assessed to be mechanical lift sort of once in that 24-hour period, that they're going to keep that consistent, and they are going to keep that person in mechanical lift. I understand the reason in terms of that consistency. The problem, though, is that you're not enabling that person to maximize their participation and independence, if we go back to that other important point. So I think that the staff need to look at that in terms of safety and say, what is going to be the safest? So if the person is absolutely consistent and reliable in terms of helping to bear weight in the afternoon, then you may look at somebody like that who is going to be lift in the morning and yet an assisted transfer in the afternoon. But again, you have to weigh everything out, look at safety first and foremost. So making sure that clients are assessed, different times of day is really important, because on the other hand, you also don't want to have it where they're assessed to be a transfer, and meanwhile they're going to be mechanical lift a different time of day, but whoever was doing that assessment didn't capture that. And so we end up with the risk of injuries and falls because of the fact that the person's abilities have changed based on the time of day. If you're using something like the logo system in order to clearly identify that, some organizations we've seen have gone to sort of a color coding. And so it's clearly identified that there is a different protocol to be used based on the time of day. And again, it's up to the organization to decide if that's something that they would want to consider. So the other thing is making sure that there has been increased communication and training as needed regarding particular clients and their capabilities and needs. And so you may find that the person doing that mobility assessment, especially if it's a transfer, may have to provide a little bit of one-on-one training with the staff to indicate, what's going to enable that individual to provide as much of their maximum participation and independence. Because sometimes people respond better to certain cues, to using a certain piece of equipment, and so training may need to take place in order for that to be safe. The other thing that is really, I think, important, well, I have a lot of things I think are important, but the mini assessment. So the mini assessment, also known as the CARE assessment, is something we've always asked the frontline workers to do prior to moving anybody. So that doesn't matter if it's the morning, it doesn't matter if it's the afternoon, the evening time, but any time that you go in to provide any kind of mobility, it's important to make sure you go through this sort of mental checklist. This is not a documented thing. I would recommend that there be documentation if there has been any risks identified. But if you go through that mental checklist, you've kind of ensured that it's safe to proceed as you always have. So C stands for communication. So has there been any change in the client's ability to communicate? Are you making sure that if you're working with another caregiver, have you communicated? But that communication piece, if there's been any changes whatsoever, you need to kind of take a step back and say, you know, is this really safe? Or is it a new staff member? Do we need to talk a little bit about the technique? And depending upon the resident or the client, this conversation may not be good to have in front of them because this can create some unease and agitation. And so it's important to make sure that communication piece is there. A stands for abilities. So has there been any changes in anybody's abilities that may indicate that the risks have increased? So has the client, has there been any changes in their strength or range of motion? And this is particularly a concern if they are a weight-bearing transfer, then you know, we could end up having a potential fall situation if their abilities have changed. What about even the caregivers? You know, if they're feeling tired and weak, if the demands have been greater on the floor that day, their abilities also have maybe changed that may indicate that this may not be safe. And that is up to an organization to decide how you're going to proceed if somebody identifies that they don't feel safe to go ahead and perform a one-person transfer. Is that support there for that individual? R is resistance. So is there any kind of resistive behavior that may indicate that it's not safe to move forward with the procedure? So is the person using verbal resistance? Is there physical resistance? And one of the things we always ask the caregivers to do is to sort of say, you know, do I really need to do this at this point in time? Would I be better off to, you know, stay and talk to the individual? Because some people will respond to, you know, sort of quiet communication, calm communication. Other individuals will respond better if you give them some time and you come back in the room and it's as though nothing ever happened. So I think that, you know, usually what ends up happening is over time caregivers get to know their clients and their residents quite well, and they can make those kinds of decisions. But it is important that if it's not an emergency, if the person is being resistive, there's nothing that says that you have to do this at this point in time. E is equipment and the environment. So it's up to the frontline workers to make sure that the equipment is safe to use. So making sure that, you know, the slings are in good working order, giving a quick visual inspection. I always encourage the caregivers to make sure that they're tugging on all the points where it's going to be, you know, going into the mechanical lift, to making sure that, you know, there hasn't been any fraying of stitching or anything like that. Making sure that the environment is clear. People often, I find, not take the time to move equipment in a way that's going to make it a little bit safer and easier to use because it's going to require them to move another piece of furniture. But taking that extra 30 seconds to a minute to move something else out of the way makes a lot more sense than working in an awkward posture or position that could potentially lead to an injury. So it is the responsibility of the caregiver to go through that mini assessment in their head. And as I said, this is not something that, you know, we're asking people to document every single time, only to document if there's been a change that has identified that the status has changed or the equipment's unsafe, and then that way either equipment can be fixed, or if it's a status change in the part of the resident or the client, then an assessment can be done. Maybe it's one of those temporary things, like it's the resistive behavior, but if it's something more permanent in terms of the abilities, then we need to make sure that an assessment does get redone and a new procedure has been identified. So the other thing is the timing of work. I have worked in some organizations which have done a fantastic job with creating sort of plans or flows of work. And so they may have it that, you know, the caregivers will actually split apart and they will, you know, work on assisting the people who only require one caregiver. And then they come together, work as a team, and the two of them go together from room to room and getting those individuals up that, are a two-person. And that's, it's amazing to see it work, because it's fast rather than you're always trying to find somebody else. They actually have a routine that they go through. The other thing is you'll see some organizations do a good job of having some of the night staff get up the early risers. There's some, residents and, sort of clients that get up really, really early and they don't want to be lying in bed. So the nighttime staff, when they, if that's part of their routine, will actually assist in getting them up so it takes some of the load off the next shift. But I think it's important that organizations come together, figure out ways to do a better job in terms of the flow of work, because that's one of the things that we often hear, that I can't find anybody to help me when I need the help. And as far as I'm concerned, if that person has been identified as being a two-person, then there needs to be two-person there to actually assist in that transfer, not just one. But if it's been identified as two, there really needs to be two people there. And so we need to enable the caregivers to work together, come up with good plans for them to help enable them. We know that when there is a lack of communication, it can lead to errors. This doesn't just happen in healthcare. But time and time again, I'll hear that, sometimes caregivers don't like working together, which can be tough. Or, they have difficulties working with certain residents or patients, and it can lead to a lack of communication. And, unfortunately, I know that it does happen, but we need to make sure that we are sort of sitting down as an organization, talking to people about, making sure we have that communication, because it's a safety consideration, rather than, looking at some of the other sort of, I don't want to say schoolyard, but some of the other issues that may sometimes come up between coworkers. So I know that sometimes there are some people that they say they work together so well that they don't even need to talk. They can just look at each other and, they can make that reposition happen at the same time. And I say that's fantastic, but it's not really a good habit to get into. It's important to make sure that we continually communicate. Even when you work really, really well with somebody, you need to make sure that you're actually talking it through, because remember that it also benefits the client as well. That client is part of that team, and so they need to be part of that communication piece. They need to be remembered in the whole process. And the other thing that some places have done a really good job at is the whole two is better than one. So whenever possible, it's always going to be two people. And I know that's not always practical, especially in a community setting, but whenever possible, it's good to sort of promote that teamwork. And I think the other thing is, in other places where it seems to work well is those teams will sometimes actually rotate. So people don't get too comfortable working with one individual. It might be that they rotate it by shift or sometimes by week. It's really up to the organization, but I find that when there is some forced rotation, it is a little bit better than when it's sort of, I work with this person all the time, every single day. It may not always be practical in every environment, but when you can, something to consider. So the other thing we often hear is that there's not enough time. So does it really take more time to maintain a neutral spine? Is more time required to get close to somebody to reduce that distance? We know that getting close reduces the load on the spine by a factor of 10, just by decreasing something by arm's length. And does it take more time to properly communicate? And this is one of the things I often get challenged with when we're doing the education sessions, is that people say, well, I don't have time to use good body mechanics. And so when we get to practicing it and using these techniques, by the end of it, they're usually like, well, yeah, you're right. It doesn't take any more time to take that step in. It doesn't take any more time to maintain that curve by sort of sticking the buttocks out and rather than sort of bending from my low back area. We've seen it work in a lot of long-term care facilities and community-based organizations. We know that it can work. So I never take these ones as good excuses. So when we look at the proper techniques, again, the body mechanics, it doesn't take any more time to use proper body mechanics, but using proper techniques. People say, well, it's just faster, when I lift the person rather than when I transfer them. But the thing is that when you lift, you are taking the entire weight of an individual to move them from one surface to another. And when we reposition, we are supposed to be moving them on the same surface. And that's one of the reasons why these slider sheets have been extremely effective. And, when you look at putting the repositioning sheets or the slider sheets in place, you're looking at somewhere between $100 up to $500, depending on the piece of equipment that you're using. And yet, the cost of an injury can be, simply like just a simple, straightforward injury, $5,000 to $10,000. So, I mean, it makes a lot of sense to have this equipment available. And the other thing is then we're not lifting. If we have the slider sheets, it reduces the force on the caregiver by about 80%. When we looked at measuring forces between using a slider sheet versus not, it was a big reduction in force. And the other thing is that it actually then reduces that shear force on the client as well. So you're less likely to get sort of skin breakdown and friction. When we see caregivers sort of lifting when they're supposed to be transferring, they're essentially taking the entire weight of that person who's supposed to be assisting to stand, and they're kind of lifting them almost sort of underneath the buttocks area and lifting them over to their wheelchair. And that's a huge strain on the caregivers. And remember, it's not enabling that client to be as independent as possible. So you're not maximizing their capabilities. You're not doing them any favors, because if they're not using those muscles even for that little bit of time, it can result in their inability to do it over time. So it is important to make sure that people are using proper techniques. And, a lot of times I find the caregivers don't even know that they're lifting. They think that they are just repositioning or they are just transferring. And it doesn't come out until you do the training and the hands-on piece that they realize, what they've been doing the whole time. So the other thing is not engaging their abilities. So one of the classic things that we see when we're doing transfers is that we don't enable the client to actually stand. So what ends up happening is the person is sitting back in their chair or like on the side of the bed, and the person might be sitting with their back straight, and then we've got the caregiver leaning forward trying to bring them into a standing position. But it's almost impossible for that client to help because two things, their back is straight. So you really need to make sure that you lean the shoulders forward and bring the shoulders almost over top of the knees. But the other thing is you need to bring them forward, either towards the side of the bed, or you need to bring them forward in the chair. Otherwise, you're not going to be able to stand up. I would challenge anybody, now or when you're done the session, to sit back in your chair and to try to keep a straight back and try to stand up. Your body naturally wants to push forward when you're standing up. And if you've got a caregiver standing right in front of you and not enabling that position and that movement forward, the weight forward, they can't stand. And then we've got the caregiver saying, oh, that person can't stand, they're not reliable. But meanwhile, what have we done to enable them to stand as best as they can? So it is important to make sure that we're using proper techniques, not only to prevent injury for the caregivers, but also for the client as well. So we're often told by management that there is enough equipment, and we know that this is a challenge in the community where we have the clients are responsible for their own equipment, and many of them can't afford their own equipment. We have seen some great efforts by some of the OTs and PTs to look for funding for these individuals to be able to get equipment, or some organizations have a great recycling program where they're sort of getting equipment that's no longer being used and sort of putting it into like a bank, and that certainly can help. But equipment is expensive. But again, if you look at the cost of an injury versus the cost of equipment, it sort of pays for itself. And I have seen even some community organizations that will sort of try to fund a certain piece of equipment when they know that person can't afford it. But they know that their staff is going to be at risk. So one of the things that's important with equipment, I like to use the 5S. 5S's, I spend a bit of time in manufacturing as well, and it's 5S is widespread, but I think you can use it in any work environment. And basically what you're doing is making sure that equipment is always going to go back to the place where it's supposed to be found. So if it's sling that's been assigned to a particular individual, it might always hang on the back of the door or wherever it might be. Or maybe if it's something that's a shared piece of equipment, it always has to go back to the same place. So it should have a home where that equipment will live. It needs to make sure that it's always clean so that it's ready to go for the next person. So if you've got standard practices in place when it comes to hygiene, then making sure that those steps are followed prior to putting that equipment back. Making sure that there are standardized and best practices with regards to the use of that equipment that should be in place. So making sure your policies and procedures include the use of equipment, making sure that the equipment is, as I said, stored or put away if it's not being used. And the other thing is to make sure you're sustaining that. So make sure there's always ongoing improvement, always looking at inventory, because clients and residents' needs change all the time. And so maybe you've got a piece of equipment sitting in somebody's room that's no longer using it, so it needs to go back into a storage, and take regular inventory, whether that be on a monthly basis, that'd be preferable to sort of a quarterly basis, and not just an inventory within a unit, but what about a whole organization? Because you'd be surprised what you'll find sometimes when you go, when you do one of those sort of audits and investigations. Some of the other things that we've seen that has been quite effective is we've had organizations train back care champions, and their whole sort of focus is more on providing feedback for their coworkers, which can be sometimes less sort of threatening or intimidating than having a supervisor. But it's meant to be friendly, it's meant to be non-confrontational, but just people who have that sort of, have taken on that role of having a bit of extra training when it comes to body mechanics, and being super comfortable with the transfer techniques and the use of equipment. And so they're a resource for people to go to, but they're also, there to provide continual feedback within their units. Do's and don't posters, I think they're great. They shouldn't be the only tool that you use, but I think it's great to have that reminder and having visual feedback, even taking actual photographs with your own equipment, so that it's not just another sort of poster on the wall, but sometimes people find it fun when it's their coworkers, or it can be a little bit more effective. And the other thing is looking at having fact sheets or things like that available, having little information available with regards to maybe back care week or neck care, shoulder care, and doing that during the shift change huddle, even if it's just a few minutes to share a couple of ideas, a new stretch, whatever it might be, but keep it fresh and keep it moving, because oftentimes it does get forgotten about. Client handling training will happen maybe once a year. As I said, some places it's longer than that. And there's not sort of ongoing information and feedback, and it loses momentum and sort of importance. And so if you can make something part of the shift change huddle at least once a week, maybe. Yes?
It's
It's already 10:02. Sorry,
to say
I'm almost done.
3 minutes just to wrap up.
Yes.
Great, and you're well on time.
Okay, I'm almost done, so that's perfect. Okay, thank you. So I think this is my last slide anyways, but the other thing is making sure that the staff are trained on musculoskeletal disorders and prevention in the workplace. We put all the emphasis on making sure that the frontline workers are trained, but again, circling back to what I was saying earlier, it is important that everybody be trained so that there is support from the top down, and making sure that we listen to the frontline workers. They have some fantastic ideas. I like going in and working with the frontline workers. It can be a lot of fun. When I'm going in and doing ergonomics, they often have the best suggestions in terms of making improvements to the work environment, the workplace, and even in moving the clients and the residents that they work with. And I think we need to sort of listen to them a lot more than we certainly do, because, like I said, they have fantastic information. But it's really what it comes down to is the supervisors and the managers that have the power usually to make that change. So it really needs to be a real teamwork in order to make things happen and to reduce that injury risk. And again, it's not just for the frontline workers, but this is also going to affect the clients just as much. And I think that's really, really important. And I think that is all my slides. Yes, that's my last one.
Wonderful. Thank you so much, Claudette, for a very informative, practical session. And I think in particular, the emphasis on the client being part of the team will do us all well. You have supported extremely well the Government of Ontario's Ministry of Health and Long-Term Care Patients First Action Plan by addressing quality improvement and safety for not only the client and the patient, but also for the caregiver. and on behalf of our director, Jack Callahan, who's been with us for this entire webinar, he'd like to thank all of you, all of our participants, and Claudette. CRE-MSD is very encouraged by the involvement of the community and your engagement in CRE-MSD and PSHSA's community of practice, and we look forward to growing these webinar series over the year. So I am now going to turn this over to Henrietta. We are going to engage in a question and answer session with Claudette. So thank you, and we will be monitoring your questions now, so please type them into the chat box. Over to you, Henrietta.
Thank you, Catherine, and yes, Claudette, thank you again. A great presentation. I'm just curious how many people tried to stand up without leaning forward while Claudette was speaking. I know I tried it a couple of times and I couldn't get off my chair. So that's you know, those simple little things are great tips, I think, that we will keep forward and be able to share. So if anyone has any questions, please type them in. I also very much liked your comments about the participatory approach and getting frontline staff to help with solutions. They do have, you know, a ton of great ideas. So someone put their hand up, but Tina, I don't think they can speak. They can only chat, correct?
That's correct, Henry. People can only type into the chat box.
Okay. So Lucy had a question here. What does your training cover as far as bariatric assessment and handling?
So we, in the training program, there is some piece on the bariatric, and with regards to the algorithms, Audrey Nelson does have some great assessments in terms of the bariatric assessments. And so, I mean, we do touch on a little bit. I have to admit it's not a big focus of the program. Unfortunately, with a lot of bariatrics, they are more immobile. But there is a fantastic equipment in place. And I think the biggest thing with the bariatric is making sure that they are properly assessed, making sure that there is the right equipment for the staff to be able to use. You know, slider sheets are different for bariatric individuals, as well as there is different mechanical lifts and sit-to-stand devices that need to be considered when you have bariatrics. So it's not that we don't, you know, spend we don't spend a lot of time on it, unfortunately, but we do recognize that is a challenge in healthcare.
Okay, and I do want to point out as well that we at PSHSA are looking at our current Handle with Care program, and we've been working with St. Joe's in Hamilton, who have a very good bariatric program, and we will be adding a section on bariatrics to the Handle with Care program, so that will be coming. So someone asked a question about Audrey Nelson. Where can they get her information, Claudette?
Well, I mean, I remember seeing her speak back in when was that, 2006, I think, down in the United States. So she's American, and she's written several books in terms of client handling, patient handling. So if you Google her, Google everything nowadays, right? But she does have some fantastic resources and has done a lot of work with respect to client handling. And I know she was a great resource for me with her algorithms before, you know, PHSA, I can't even talk anymore, brought out their algorithms when Frances really worked hard on hers. So, you know, but she does have several publications.
Okay. And I just want to point out, in case people aren't catching it as it goes through, there are some comments I think that really resonated with people, and a couple of them I wanted to acknowledge. One is about adding the quality lens, how important that is, and I think that is a key piece. This is also a quality of care issue. The importance of communication between the caregivers and the patient. So your comment, Claudette, about people being so in tune that they don't actually need to communicate. We can't forget that we have someone that we're providing care for, and we want to communicate so they know what's going on as well. And someone had mentioned that they use the CARE document in training? And
Okay.
do you have any other resources you can share? So there, you can purchase the CARE cards, and the CARE poster is free of charge on PSHSA's website that you can just print and copy and put up wherever you wish. So I'm not sure, do you have any others, Claudette, to mention?
No, I mean, I think that, you know, I find that the nice thing about the Handle with Care program is that it is put together based on a lot of research. So I think it's a really good go-to. Other than, as I said, I've used the Audrey Nelson. I've used some of the research that has come out of the States. I kind of try to always keep an eye on things in terms of one particular resource. I don't, other than the Handle with Care, I haven't really had another go-to. There is also the logos too, Henry, as well, on
Right.
that's successful, that people can print those off and use those as well.
Okay.
Yeah. Yeah.
And someone made a comment about Alberta Health working on a bariatric model. So I'll connect with them. We do have a national alliance, PSHSA does, with other safety associations, and there's 7 provinces that have a healthcare safety association. So I'll connect with them and see if there's some components we can use when we do the upgrade to Handle with Care. So thank you, Brooke, for that information. Someone else made a comment about how important manager and supervisor training is as well. So that was a good addition. And then a little question for you about timing of the one-person transfers, and then have your comment about then the team would come together and do the 2-person transfers at the end. Have you had any concerns, or how would you deal with clients not always wanting to be the last ones to get up?
Yeah, well, that's a great question. I think that what a lot of organizations have done is they've done where it has been effective is they've done a good job identifying, because you're always going to have some of those residents or clients who do want to be up first versus those ones that would stay in bed as long as they possibly can. And so they have worked together with the residents or the clients to determine, what's going to be the best flow of work. So I don't think that it's sort of a one-size-fits-all solution. I think it has to be based on the capabilities of the clients or the residents in addition to their wants. I mean, there are the individuals who do want to be up early. You figure out a way to make that work, because I find almost always on each of the floors there's people who would stay in as long as they could. So it's just a matter of making sure you spend the time to look into that first.
Okay. Any creative ways to engage staff in a large organization to achieve annual sign-off on the review of the client handling practice? So how can you get people excited to want to do their annual training, Claudette?
I think that the biggest thing is where I've seen it work again is it's coming back to where management has demonstrated that commitment and that support. Because a lot of times what I hear from the frontline workers is like, oh, we have to go through this again. So I think that if there's a way to get management and to get the supervisors involved in promoting it and showing their commitment and demonstrating that they've had their own training as well, I think that's really important to get that momentum going. And making sure that there is visible indications that everybody is committed to doing it. So it's not just another thing that people have to go through the motions as part of their health and safety training. And in terms of creative ways, I've seen all different kinds of things, whether it be posters, whether it be sort of kickoffs, in terms of making it sort of more of a fun event. But I mean, every organization is different. I'm not sure sort of how large of an organization you're talking to, but I think the biggest thing is that commitment from the top down, and it's visible. And then people get more excited about it.
It's Catherine. I see we're almost at 1 o'clock. We have one more person typing a question, so we'll take that question, and then I'll just make a few closing remarks. I see that question still being typed. Maybe it's a little long. What we can do certainly is encourage you to send any questions that we haven't been able to address today to Bettina Butler at CRE-MSD. You will find her email, if you don't have it in front of you, on the CRE-MSD website. So in the interest of time,
Catherine, the question is up now.
Okay, great.
Claudette, you mentioned about exercise programs for caregivers and an assessment of both caregiver and clients prior to the lift. What exercise program is available?
Well, I mean, it's something that usually is very organization specific. I mean, there are some training sessions that we do for some of the ones that we work with. We actually add in a stretching and strengthening component that we give to the frontline workers and to whoever's attending, so management, supervisors, where we focus on key core strengthening exercises that the staff can do, as well as stretching on the job and at home, so that people have not only the flexibility but the strength to be able to do their job safely. Oftentimes our jobs involve just very certain specific muscle groups, and when the other ones get neglected, we have an imbalance, and then we're increasing our risk of injury. So it's not uncommon for us to be requested to either do a separate education session with regards to stretching and strengthening for caregivers, or else we just sort of add that in as part of the training session.
Okay, thank you. Over to you, Catherine.
Thank you. Thank you, everyone, very, very much. And that question on exercises was a great segue into mentioning that we have two CRE-MSD webinars coming up. One in June that will address exercise and its relationship to the reduction in MSD. So I'm sure our participants today will be interested in that. And in less than a week and a half, on April the 11th, we have a webinar coming up that will specifically address the basic components for personal support workers to work with clients to not only strengthen client mobility, but to look at, again, what they need to be doing to facilitate better mobility. So I would encourage all of you to join us again on April the 11th, and I'd like to thank Henrietta for facilitating the question and answer period, for Bettina Butler behind the scenes for facilitating the technology aspect of this webinar, and Claudette for a wonderful presentation, and to all of you for supporting CRE-MSD and PSHSA in sharing potential solutions to prevent musculoskeletal disorders. Thank you, and we will see you again, hopefully in a few weeks. Take care.